Well, it is clear for many years that people with diabetes, especially type 2 diabetes, have an increased risk of cardiovascular disease, and that the main cause of mortality in people with diabetes is cardiovascular.
Yeah.
What became clear is that also renal disease is very important, and actually that there is a big interplay between renal disease, diabetes, and cardiovascular disease. We as endocrinologists or doctors taking care of people with diabetes knew this interaction for many, many years.
Yes.
And so it's a bit funny to see that now also cardiologists and nephrologists are all of a sudden realizing that all of this comes together. Because indeed, it comes together. It's like a bad, perfect storm where hyperglycemia, dyslipidemia, hypertension, hyperinflammation, everything comes together.
Yeah.
And when you have impaired kidney function, this is even accelerated.
Yeah.
So it is important to acknowledge that people with overweight and obesity, especially when they also have hyperglycemia, so type 2 diabetes, when they also have impaired renal function, you have the perfect storm, the worst of conditions to have bad health outcomes when it comes to cardiovascular disease. So what we wanted to put forward was that it is important to approach these people in a holistic manner.
Yeah.
And not just focus on lipids, not just focus on glucose, not just focus on hypertension, but look at everything together. So people with type 2 diabetes, with cardiovascular disease, with renal disease, with everything coming together, it is important, first of all, to be proactive.
Yeah.
So not wait until you have very advanced renal disease, but to be aware already at a stage of microalbuminuria that these people need to be treated appropriately and timely in an aggressive manner. And so we need to approach these people holistically.
Yeah.
We need to take care of glucose. We need to take care of hypertension, of lipids, of inflammation. And what we have now as the big opportunity is that we know that indeed losing weight, lifestyle, exercise, and healthy eating is very important.
Yes.
But also using agents that are directly disease protecting, like the SGLT2 inhibitors and the GLP-1 receptor agonist, is crucial in these people. Because lifestyle alone, glucose measures alone, hypertension alone, lipids alone are important to be attacked. But on top of it, if we have these SGLT2 inhibitors and GLP-1 receptor agonists, we know we affect the outcomes of these people, both on the cardiovascular and on the renal endpoint. So it is important to consider the whole entity of the cardio-renal-metabolic syndrome, especially in people with overweight, in people with type 2 diabetes. Honestly, it's all semantics. It's all different words to see this, to say the same. In the end, it doesn't matter.
Okay.
All of these definitions by all of these learned societies or all of these groups. The most important thing is that clinicians, doctors treating patients realize that every person with overweight or obesity or every person with type 2 diabetes is at a high cardiovascular and renal risk. And that we need to be aware of that, that we need to look for it.
Yeah.
So every person with overweight or obesity, every person with type 2 diabetes should also have microalbuminuria control to see is microalbuminuria there, and if it's there, to take proactive measures. Introduce, for instance, SGLT2 inhibitors, introduce, for instance, GLP-1 receptor agonists, tackle hyperglycemia, tackle high blood pressure. So we need to be aware. Also, in everybody with overweight or obesity, everybody with type 2 diabetes, we need to look proactively for cardiovascular disease. We need to be aware of aspects of cardiovascular disease that are not so well known, like heart failure. So we as clinicians need to be aware of heart failure in our patients and look for it by listening. Are you short of breath? By doing some extra measures like pro-BNP. And also, again, look for it and take action. Bring in the SGLT2 inhibitors, bring in the GLP-1 receptor agonists. So whatever the definition, it's always the same. Be aware as doctor, look for it, cardiovascular disease, renal disease, and take action early in the course of the disease, proactive, and when the complication is there, take the appropriate action. Lifestyle, control of all the risk factors, and have the organ protective agents like SGLT2 inhibitors, GLP-1 receptor agonists on board. The question of women and type 2 diabetes and women and cardiovascular disease is a complex one. Because most of us doctors have learned in medical school that women are protected against cardiovascular disease because of our estrogens. And that's true. Premenopausal women have relatively less cardiovascular disease than men. But once we are postmenopausal, we catch up. And so it is a fact. Many studies have shown that if a postmenopausal woman comes to the emergency room with complaints of angina pectoris, that doctors don't think of cardiovascular disease because they still think women are protected against cardiovascular disease. And so a woman with an MI is diagnosed later than a man with an MI because of this concept that we get as medical students that women are protected, and it's not the case in postmenopausal women. On the contrary, when we look at type 2 diabetes and overweight and obesity, it's even more in women. And so often women have different risk factors that accumulate for cardiovascular disease, whereas the doctors think women are protected. So we need to change the message to the young doctors and the older doctors that once women are postmenopausal, they're not protected against cardiovascular disease. And so the sad reality is what I already said, that we diagnose cardiovascular disease in women too late. Second, when we look at use, for instance, of statins in women, in women with type 2 diabetes in particular, statin use is less in women. Why? Because doctors just prescribe it less. So when we look at attaining the targets of blood pressure, attaining the targets of lipids, of glucose control, for instance, it's always less in women. Unfortunately. Why? Probably because doctors think it's less important to have it in women. When we go to the big cardiovascular outcome trials that have been done with SGLT2 inhibitors and with GLP-1 receptor agonists, there are women there. There's less women than men, but there are women there. And when we look at the effect of SGLT2 inhibitors or GLP-1 receptor agonists, women versus men, the protective effects are the same. And still we see they're used less in women. So it's really everything that is against the woman. First of all, the concept that women are protected, it's not true after menopause. Second, the fact that women accumulate risk factors for cardiovascular disease after menopause. Third, if we look at the use of statins, antihypertensive, and glucose-lowering therapies, it's always less in women. Also, SGLT2 and GLP-1 is less in women. And the effect is the same. So the benefit for women is the same. So it's really a call to action, and that's the talk I will give in this IDF. It's a call to action to be aware that women, especially postmenopausal women with type 2 diabetes, are at very high risk of cardiovascular disease, and we should again be proactive and use disease protective, organ protective agents like SGLT2 inhibitors and GLP-1 receptor agonists in women, because they're not protected. They have a high risk. So SGLT2 inhibitors and GLP-1 receptor agonists, you call them glucose-lowering agents, and that's where they originated originally. We first described them as glucose-lowering agents. But we now know that they do much more than just lower glucose.
Yes.
So they have been tested in people with type 2 diabetes, but also in people without type 2 diabetes. And what has been shown is that they protect the heart and that they protect the kidney, both the SGLT2 inhibitors and the GLP-1 receptor agonists, as well in individuals with type 2 diabetes as in individuals without type 2 diabetes, for instance, individuals with obesity. So it is clear that these are the preferred agents to really change the outcomes in people, especially with type 2 diabetes. About women, what I said before is that when you look at all the big trials with SGLT2 inhibitors and GLP-1 receptor agonists, the benefits on cardiovascular outcomes, the benefits on renal outcomes are the same between men and women. So same benefit.
Right.
Now, if we're critical and we look at the side effects, then we need to be a bit more careful. Like for SGLT2 inhibitors, for instance, as you know, they act also by losing glucose via the urine. And so because of the build of our genitourinary tract, we as women are a little bit more predisposed to have the genital and the urinary complications of SGLT2 inhibitors. So there is a higher prevalence of the infections, especially the yeast infections, but also the bacterial urinary infections in women are more frequent. And so for doctors prescribing SGLT2 inhibitors, it is very important to, first of all, listen to the woman sitting in front of you, whether she has a history of genital infections or urinary tract infections. And if this woman has recurrent infections already before the SGLT2 inhibitor, you may have to think twice before using these agents, because chances are very high that this woman will suffer from this complication with an SGLT2 inhibitor, and there you may prefer a GLP-1 receptor agonist. Also, when you don't have the history of genital or urinary tract infections, when you prescribe an SGLT2 inhibitor, you may want to inform the woman sitting in front of you about hygiene, you know, about washing with water after urinating, not washing with soap, because that dries out the mucosa. So just with water, the normal, regular hygiene is important to take into account when using SGLT2 inhibitors. And again, thirdly, listening as a doctor and asking specifically to the patient, especially when she has type 2 diabetes and you give an SGLT2 inhibitor, listen if she has genital infections or urinary tract infections. And if she has them, treat them appropriately. When an infection is happening once, you treat, you don't stop the SGLT2 inhibitor. When it happens twice, you may want to stop the SGLT2 inhibitor, especially if it's recurrent. For GLP-1 receptor agonists, the side effects are similar in women as in males, namely just the gastrointestinal side effects, and there's no difference between male and female. So use these agents as well in women as in men to protect the heart and the kidneys of these people.